Okay, so welcome to SWOC. We'll get started. Just a couple announcements. Next month is November, and we don't have SWOC because we want to support the UW wound update thing. So everyone go to that. Good. Get your registration in. And then in December, of course, we don't do SWOC just because there's so much going on. Our next meetings will be in January. We'll have them here in Kirkland at Evergreen, and then we're going to start doing some SWOC meetings in South King County. We'll be meeting in Tukwila, so look for that too. So today we have. Actually, I can do the back.
You were on it.
I was. Okay. We have Julianne Simpson. She is a physical therapist, and she specializes in continence. It's something that, at least as a nurse, I never realized that PT was involved in it until I became a certified continence nurse. And there's a lot of overlapping between physical therapy and nursing for this. So this is a great topic. I love learning about it and helping my patients. There's so much that you can do for your patient, even in just like a half-hour visit. So without further ado, let's have Julianne come on up here, and she can tell you more about herself. Okay, you're welcome.
Hello, everybody. It's funny to be, this doesn't make it that loud, but I'm Julianne, pelvic PT, and I thought I'd just kind of start with what I want to cover today. It's really small. I'll read that, so that's really small. But in terms of objectives, I want you to be able to describe common types of incontinence and what their primary features are. I want you to be able to verbally screen for pelvic floor dysfunction, and then most important part is I want you to be able to talk about how you treat different kinds of incontinence and teach you some techniques that you can use, like Deborah said, in your half-hour session with the patient that can hopefully help them improve their continence. I like maps, though whenever I travel with my family, I'm the navigator with paper maps, but never with a phone. So this is where we're going to go. Let's start off with some introductions. I also want to thank some of my mentors. A colleague of mine does this when she presents, and I kind of liked it, so I stole it. So Emily Norland is an OB, an old friend of mine, and when I was starting to think about becoming a PT, when you're going to PT school, you have to do a bunch of observation hours, and she suggested, you should observe where I send my patients. And I was like, you send your patients to PT? And that led down this path of observation and being curious about what pelvic PT was about. So here I am, thanks to Emily. Carrie Hall is the president of Movement Systems. She's really all about treating a whole patient and what she calls lifestyle medicine, so incorporating exercise and food and sleep more than just how their body's moving. And then my former colleagues from Swedish, Debbie and Peg. Do you know Peg? You should meet Peg. She's a brilliant pelvic PT. And then my fabulous husband, Bjorn. He has put up with cleaning up after dinner for the last 2 weeks so I could prep for this. So he's home with both kids tonight, so thanks to my husband. And then here's my family. Can't resist, picture of cute kids. This was, I think, day 7 of an 8-day camping trip, so we're all a little dirty. This is Connor, this is Goldie. She's 5, he's 2.5, and they're so cute, they melt my heart. So this is me. I'm a pelvic health PT. Did most of my training through Herman and Wallace. I have my doctorate in physical therapy from Eastern Washington University. I did not take the straight path to PT. A lot of my grad school classmates went from undergrad to PT school. And I graduated undergrad. My degrees were in history and theater, worked in theater and then recruiting for a while, changed careers to PT. So kind of done a little bit of everything. 2 kids. I like to ride my bike. In theory, I surf, and I used to play a lot of ultimate. Surfing is hard to fit in when you have 2 littles. This was the end of that same trip. We rode our bikes to the San Juans, and I think I was telling Katie, there's our long-tailed cargo bike, can fit 2 kids. So when I was talking with my husband about what I was going to call this lecture, this talk, he thought I should call it Continence, not Continence. He's very silly. So now I want to get to know you. I've kind of talked to some of you. So how many of you work in home health? Is that almost everybody? About half. And then how many of you work outpatient? I know Deborah does. And then how many of you work inpatient? Great. And does everyone do mostly wound care? Okay. So some people do. So what do you do that, what else do you do?
I'm a health manager.
Cool.
As a CWCN.
Cool. Nice job. And I found out about your organization because my sister-in-law is a wound nurse. And she suggested I reach out and see if you guys wanted to hear about continence. So thank you to my sister-in-law, Margaret. So then Deborah kind of alluded to PTs. Like, what does PT have to do with continence? You think like, I had a total knee, I fall all the time, or I dislocated my shoulder. This is another kind of boring, small slide, but basically, what's PT got to do with it? According to the APTA, which is our professional organization, we diagnose and manage movement dysfunction. That's the boring part. The exciting part is we enhance physical and functional abilities. And if you think about continence, it keeps people home. Right? It keeps people from feeling that they can engage in society and with their friends. And if I can help someone feel more confident about being in public, they're going to be mobile for longer, right? And they're going to have fewer falls and live for longer and be potentially happier. And then restore, maintain, and promote physical function, but optimal wellness and quality of life. And it's really the quality of life piece that keeps me going. I love helping my patients. Imagine for you guys too, right? You love helping your patients have better lives. And then the last bullet is prevent the onset, symptoms, and progression of impairments, functional limitations, and disabilities. So that's kind of what we do, and that's how continence fits in. Here's a little more about why PT. We are movement system experts. Incontinence doesn't occur in a vacuum, right? If you're leaking urine when you're, say, on a trampoline, maybe using an example from the room, but you may also have weak hips. Your pelvic floor probably isn't functioning perfectly. Your pressure system, I'll talk about a little bit. Your core isn't functioning perfectly, and these are things PTs can help with. We also treat tissue, muscle, and joints, so we're familiar with what good tissue quality should feel like, just like you guys are, right? You see a lot of unhealthy tissue. We see a good mix. And then we also try to look at a whole person, and we've got a lot of time. I spend an hour with my patients, once a week usually. So lots of time to like get to know them and really help them kind of manage their life, their whole life. I also treat from a biopsychosocial model, so looking at the patient within the context of themselves and their life and the world and their biomechanics and how their body's moving. We're also pretty good traffic cops. Like you guys, you tend to know who to see about what, right? And if I see a patient with something like, oh, you really should see colorectal, or you really should see urogyne, they usually listen, which is kind of delightful. And then, like I said, I spend an hour with my patients once a week, so I've got lots of time. And I'm in a very special clinic. Not every PT has that kind of time, so I feel very fortunate that I have that much time. Let's talk about anatomy. Did everyone get anatomy handouts? They're over here. You won't necessarily need them. I'm going to have pictures up here, but so I also brought a pelvis. So let me, let's see, this is a little hard. Okay, see if I can talk in here. So it's a female pelvis, and there's a rectum, a uterus, bladder. And if you look in, I'm going to pass it around, but as you look in, you can see, and all the organs pull out. Feel free to pull them out. But I recently, in our clinic, we have heaters where there are little plastic pieces that pop off, and I recently dropped the rectum into the heater and had to get the facilities guy to come fish it out. So try to at least make sure all the pieces end up back with the model. But the pelvic floor makes a supportive bowl around the pelvic organs. And then flipping up, you can see there's 2 layers of muscle. Actually, this one, so you can see it up here too. 2 layers of muscle, superficial, and then deeper. Superficial muscles close, deeper muscles lift. So I will pass this around. Excuse me. So let's just talk about this view since I've just alluded to it. But you've got your urogenital triangle up the top, which urethra, vagina, and then around your anus is also superficial, your external anal sphincter. Your levator ani are the deeper muscles, they lift. And then let's just go back a little bit. So here's a section view. A lot of us know this anatomy, right? But it's always good to see it. So I just want to call out, here's pubic symphysis, pubis, coccyx, and then bladder, urethra, uterus, vagina, rectum, anus. And here's the pelvic floor, Right? All of those systems cross the pelvic floor. So if you're having pelvic floor dysfunction, you might be leaking urine, but you might also have some prolapse, or you might have like a harder time holding in gas. So all of these things can be related, and for a lot of my patients, especially my pain patients, don't always put together that all this stuff is related. And then I also treat men. Male continence is a little different than female, but the anatomy is basically the same, right? Pelvic floor makes that same hammock, prostate instead of a uterus and vagina, but otherwise largely the same. Male pelvises are differently shaped. They tend to have more muscle mass, but it's not all that different. And this is interesting. So we kind of already looked at this view. This is the bulbal spongiosis on a woman. And there's more clitoral anatomy. I always talk about this, forgive me, for clitoral, you think of clitoris as just that little thing. There's actually another big section of the clitoris here and here, right under the bulbal spongiosis and the ischiocavernosus. So those muscles are really involved in sexual function, and then they're the same muscles on a man. So bulbal spongiosis helps keep blood in penis, so does ischiocavernosus. So just like to call out that our muscles have not just a continence function, but also a sexual function. Questions before I move on about anatomy? Thoughts? Ideas? Okay. Forgive me, I'm just getting over a thing. Chest thing. So the next thing I want to talk about is respiratory diaphragm. Pelvic floor is also called the pelvic diaphragm. And because, can people see this picture? Because these muscles, basically, there aren't a lot of muscles in our bodies that run horizontally. Most muscles run up and down. These muscles really work together, right? Your diaphragm moves air in, essentially, lets air move out. It's also a really important part of your core. So this is all showing transverse abdominis, which is your deepest abdominal muscle. So the diaphragm, actually, if you reach for something, that side of your diaphragm is going to isometrically contract to stabilize your trunk, whether you're inhaling, whether you're exhaling. And it's also important for coordination with your pelvic floor. Okay, I hope this little GIF works. Oh, it does, good. Oh, is it going to go? It was going. It's moving over here, but not moving up here. Okay, I'm going to turn this. Can I turn this? Okay, can you guys see this at all? If you want to see, feel free to come up and take a peek, but it's breathing. Yeah, so it's funny that it's not working up there, but so when you inhale, your diaphragm flattens out, moves down. Pelvic floor should move down. Abdominal wall should move out. So this whole system kind of moves together. So a lot of times when there's pelvic floor dysfunction, there's also some kind of breathing dysfunction because they work together. They're opposite ends of the same canister. And this is kind of a cool concept. And can I send you a link to this little GIF so people can see it because it's kind of a cool one. I get all excited about things there's like little things you can show your patients that are like quick and easy and give them a sense of what's really going on. And this is where we get to, I hope, let's turn up volume on here. Julie Wiebe is a PT, she's based in California, and she does a lot of work on basically what I've been talking about, diaphragm, pelvic floor function, and she works with a lot of high-level athletes who leak, like CrossFit athletes who are leaking. And I don't work with people that high level, but she has some pretty good takes on that. So let me see if I can make this play. Deborah, I might need your help. It's not letting me get out of the presentation to play the video.
Ooh, I'm not sure.
Okay.
Sorry.
So let me just we'll send out the video by email. But basically the idea is, imagine a balloon. You have a balloon full of air. Your diaphragm's the top of the balloon. Your pelvic floor is the bottom of the balloon. So you can imagine that if you were to push down the top of the balloon, the rest of the balloon would get a little bit bigger, right? And then when you let go, that recoils, the balloon goes back to normal. That's like breathing, right? You inhale, moves down, expand a little bit here, expand a little bit here. The video also talks about how, now imagine, still the same setup with the balloon, but now we've added abdominals. And let's say you're over-tightening your abs, and you visualize how the top of the balloon would bulge, the bottom of the balloon would bulge, right? And then imagine jumping on a trampoline, or you cough or sneeze, how the pelvic floor could be overwhelmed by extra force from above because abs are tightening and pushing down. That's kind of what the video is about. And that gripping, I was talking with Deborah about chronic pelvic pain, that gripping can cause other accommodations in how our bodies are moving, which can lead to other dysfunctions. So look at the video at some point. Now it's time to practice. So let's practice some breathing. So everyone sit tall, find your weight in your sit bones, your ischial tuberosities. Put one hand on your sternum, one hand on your belly, and do a little bit of breathing. And just kind of observe what happens. Does one hand move more than the other? Both hands moving about the same? And if they're moving differently, try to time it so that your belly and your chest kind of rise a little bit with an inhale, fall a little bit with an exhale. And then draw your mind's eye down to your perineum and try to notice what that feels like in the chair. You know, does it feel lifted? Can you feel the seams in your underpants? Can you feel the chair? And then see if you can let your perineum be a little heavier in your chair. You might feel your sit bones widen a little bit. You might feel kind of your tailbone move back a little bit. And then keep noticing your perineum. See if as you breathe, you can sense a little bit of that kind of up and down motion as you go. In a perfect world, you should feel your pelvic floor, like we've talked about, expand a little bit with an inhale, rise a little bit with an exhale. And then check in with your abs. Are you holding your abs tight? See if you can let go of your abs and see if that changes what you feel in your pelvic floor. And then also notice what your body feels like, what you feel like emotionally. This little bit of breathing, we did, maybe a minute, 2 minutes, and can sometimes give you a little bit of a calming reset. So if you're having a stressful day, or if you happen to spend a lot of time in your car, like I imagine most of you do, right, Seattle traffic, it can be a good time to practice a little bit. And this can be a good intervention for patients, we'll get there, but with urge urinary incontinence. We're going to talk about types of incontinence. I'm going to kind of go through this kind of quickly, because you'll have the slides. If you don't have the slides already, I'll make sure you get an emailed copy of the PDF. But basic types of incontinence. So on the urinary side, stress, urge, mixed is both. Insensate, meaning you don't really know what is happening. Enuresis, bedwetting, night wetting. I'm not going to talk about these much. And then on the fecal side, there's anal, urge, smearing, stress, and then gas incontinence. Here are some definitions. Basically, stress, urinary incontinence, cough, sneeze, laugh, jump, walking, like stepping up something. Urge urinary incontinence is you feel a really strong urge, you're dripping on your way to the bathroom. I hear chuckles. Happens. And then mixed urinary incontinence is both. And then we talked about this a little bit before we started, but total lifetime prevalence, 25 to 45%. Yes, it's a big range, but either it's whether it's 25 or 45%, that's either 1 in 4 or 1 in 2 women have incontinence at some point in their lifetime. It's something that I'd like to make the world better by reducing. So in terms of stress UI, about 16%, urge UI, 5.2%, and look at the ranges, right? The ranges are huge, and it's partially because there's mixed UI, partially because there's a really inconsistent definition of incontinence. Different studies say, some will say, have you leaked in the last month? Some will say, have you leaked in the last year? And let's say you only leak when you have a really bad chest cold, and your chest cold was 6 months ago, and someone asks you if you leaked that month, you're going to say no. So in terms of research, we can definitely do a better job of being more consistent about our definitions. Here are some risk factors. Age. 5th and 6th decades are the highest risk, probably having to do with hormonal changes. Vaginal delivery, 30% of new moms leak in the first 3 months, usually infrequent stress urinary incontinence. Could we make that better sooner? Probably. I think we probably could. And cesarean delivery is about the same as not having had a baby for a stress UI. Hysterectomy is another risk, oral estrogen, and maybe carbonation. It certainly helps my patients to get rid of carbonation. Here's some mixed UI, which would also include urge UI. Obesity, diet, again, caffeine, not super surprising, carbonation. And let's talk about guys. So there's a lot fewer studies in men than there are in women. They have longer urethras, those jerks, so they don't leak quite as much as we do. But the research is the same problem, variable definitions of incontinence, so we get huge ranges. So older men, 11 to 34%, middle-aged and younger, 3 to 5. Overall, I mean, come on, researchers. That's huge, 4 to 32%. But we do our best. And there's some, with increasing age, studies are somewhat inconclusive with men. One study said urgency increased with age, stress stayed the same. Another said stress increased with age. So who knows? Aging sucks, that's what we know. Some risk factors, older age, stroke, 8 times the risk of UI. I imagine some of you in home health see patients who've had strokes. Big difference. Diabetes, alcohol, but there's some disagreement on that one. Higher BMI. And then prostate surgery. I imagine a lot of you see men who've had prostate surgery. It increases afterwards. TURP is about a 1% increase in risk, which is not that significant. But radical prostatectomy, 2 to 60%. So big increase. And that really changes based on how far out they are from surgery. So 13% incontinent at 1 year, 7% at 2 years. And I'm not sure what the definition was that these studies used, but certainly for a lot of the guys I've treated post-prostatectomy, they are just like faucets, and then slowly it improves, but it can take a while, and PT can definitely help. And then the other thing is providers underestimate UI following prostatectomy. So ask. If your patient's had one, ask. Guy's not going to be like, yeah, I leak all the time, right? But if you know them, they might volunteer, and you can help them get treatment. So I'd done all this research on men and women, and then I was like, oh, right. People have surgery to change their genitals. I should probably look at that data a little bit. There aren't a lot of studies, unsurprising. But I found 2 small studies. A study of 30 of male to female surgery. And at 12 months, 70% of the women had urge urinary incontinence, 8% had stress. And I have no idea. This seems like this should add up, but I'm just reporting the data that they gave. So, and this is a slightly bigger study, annual follow-ups. So 12% of the 120 were leaking. And then of those who leaked, of those who had incontinence, I think that's how they did it, but female to male, 3 were leaking, and male to female, they had stress urinary incontinence. And 9 of those who had incontinence who were male to female had stress urinary incontinence. So seems like it's potentially increasing risk, especially for people who are going from having male to female surgery. This I thought was super cool. It was a 50-year-old woman who'd had gender-affirming surgery, male to female, and she had a sling surgery, just like a signed female at birth woman would have. And I thought that was pretty cool. And she had good results. So hooray for technology. Okay, let's move on to FI. So fecal incontinence, you're leaking poop. Could be solid, could be liquid. Stress happens when you're coughing, sneezing, laughing. I had a patient who leaked when she walked up this long flight of stairs at work. And then we've got gas incontinence. And this one, I didn't actually know this combined definition until I started doing research for this presentation, but anal incontinence is either you're losing gas or you're losing feces. It's kind of an all-encompassing term. And then incidence and prevalence. Again, there's not a ton of studies, but 0 to 15%, like who's 0%? Someone's got to be leaking. Average 4.3%. And then over another one, 7.7%. Poor quality studies, varying definitions. I should say that I got a lot of my incidence and prevalence information from the International Continence Society. I don't know if you guys know them, but they put together a big, like 2,000-page ebook They're really working on standardization of definitions and research stuff. And it's this huge book that goes through all the studies, and they review them and update them. And there's also a huge section at the beginning. It's all about anatomy and like histology, and it's really cool. So if you haven't looked at it, it's free. You don't have to even be a member. But it's going to be a good reference if you're ever, hey, I wonder what the numbers are for this thing. They probably have it in their book, and you don't have to find all the individual studies. So fecal incontinence risk factors, obstetric trauma. This is the big one. Women who've had a 3rd or 4th degree tear or episiotomy that went that far can interrupt external anal sphincter fibers. That's kind of one of the biggest risk factors. So if you have friends who had babies and they're like, I kind of poop myself a little bit, they should go see a colorectal doc. They can do some nice imaging, and though surgery is always a risk, perhaps it's better than, maybe there's PT can help there too, but if it's a big enough tear, there's only so much I can do. Irritable bowel syndrome is another risk. If you think about, swings between diarrhea and constipation, diabetes, obesity, seems like we just should all not get heavy and avoid diabetes. And this is a big one, chronic diarrhea. 51% of people with chronic diarrhea have fecal or anal incontinence, which is a pretty big number. Sphincter colorectal surgeries, neurological disease, and then constipation. So the IBS, right, would capture both the diarrhea and the constipation and kind of swinging back and forth potentially. Here's some cost data. Questions, how am I doing pace-wise? Am I going too fast? Am I going too slow? Am I talking too fast? Okay, awesome. I'm from Massachusetts, and we tend to just go for it. So estimate was $20 billion in US dollars, estimated in $212 for urinary incontinence. And then another study broke it down by types per person. So mixed urinary incontinence, you can see the numbers, about $300 for each. Stress urinary incontinence was the least. That was in $2006. Fecal incontinence, I got a little perplexed by this crazy statement, but it sounds like the gist of this is that the more fecal incontinence symptom severity was significantly associated with higher annual direct costs. So if you're leaking more often, it's going to be more expensive. But they were estimating about $4,000 a person, medical costs about $2,300, non-medical about $209. And then productivity loss, I thought this was kind of cool, about $1,500 a year, which is interesting to think about. The time you spend changing your pads or wiping yourself off when you should be working. Kind of cool to think about. This is my favorite part, this quality of life. There was more research I could have looked at, but I tried to pull stuff that was free. So if any of you all want to go back and find stuff, you should be able to find it online. Depression, urinary incontinence. When they occur together, it's more than the sum of both, right? They kind of compound on each other. So if you have patients who are depressed, right? You can kind of tell that they are, and they're incontinent. Make sure they're doing okay, because they can make things worse. And then urge urinary incontinence may be more bothersome than stress urinary incontinence. Lower sleep scores. If you think about urge urinary incontinence, it's often associated with more urinary frequency. So those people are the ones who tend to get up, 2, 3, 4 times a night to pee. And then urge urinary incontinence, mixed urinary incontinence tend to have higher urge intensity. So when they feel an urge, it's pretty intense, and more need for medical care. And then I kind of liked this study. It was out of Holland or Sweden or something. And I think it was Sweden, because I left the umlaut off of the O of Engstrom because I couldn't figure out how to put it on there. But in men, the more lower urinary tract symptoms they had, the more negative impact on health, and they had higher sadness scores. And then sexual function is also diminished by urinary incontinence, but can be improved by pelvic floor muscle training for stress and urinary incontinence, and then mid-urethral slings improve sexual function. And then sexual function with urge urinary incontinence was improved with bladder inhibitory medications. And then UI associated with sex improved with treatment of whatever the underlying condition was. Questions? All right, let's jump into assessment. So this is where this gets fun. Let me take a sip of water. I really view my assessment as a time to get to know my patient, have them trust me. I'm going to want to put my fingers in their vagina or their rectum, so it's kind of worth it for me to take the time to get to know them a little bit. So when I'm talking to them, I take a pretty thorough history. So I'm just going to walk you through my questions. You should have these questions on a handout somewhere. But basically, I start with, do you have any concerns about your bladder function? Open-ended question. They can say whatever they want. If they say no, I say, well, how frequently do you pee during the day? Do you go at night? And sometimes they'll say, oh, I pee every hour. Like, oh, that's pretty often. Does that bother you? It kind of does. And they might say no to the first question, but when you dig a little bit, you'll find out, yes, they have more stuff going on than they really want to tell you initially. I always ask about childbirth history, obviously, if they're female, any injuries, and then, do you experience any urinary incontinence or leaking? Do you ever leak when you cough, sneeze, laugh, jump, throw up on the way to the bathroom? And then I always ask, any trouble making it to the bathroom on time? Because some people think that's a different question, right? Oh, I dribble a little bit on the way to the bathroom. It's no big deal. And then how much do they lose? Are they changing just their underwear? Are they ignoring it? How many times a day do they change? How many pads do they go through in a day? It can help you quantify, so when you're documenting, you can show some kind of improvement. You can also ask them to, like how many times a day they leak or how many times a week they leak, so you can have something quantifiable. Questions about bladder screen? Yes?
So if they're having urge incontinence, but they are only having it a couple of times a week and changing, sometimes they don't wear a pad and sometimes they go through a whole pad.
Right.
So why that? What's happening there?
Well, we'll get into a little bit of excuse me, when we get to the treatment section. Sometimes it can be associated with stress. If you think about, if you're running from a tiger, you're going to pee your pants, right? So if someone's really stressed, maybe you wouldn't pee your pants. I think I'd pee my pants if a tiger were actually chasing me. But that increased stress level can maybe contribute to urgency. There's also bladder irritants that can make things worse. So let's say someone has a pretty good diet, and then every Friday they binge on like Diet Sprite and vodka. That might contribute to some of their urgency the next day. And sometimes you can just get in a cycle where you're leaking more. And I don't necessarily have an explanation for that.
I was wondering if it had anything to do with like a cycle.
It can.
And they're in their menopausal time. And
It certainly can. I mean, estrogen is going to make all of your vaginal tissues plumper, thicker, juicier, including your urethra. So if you're having less estrogen, maybe you have part of the continence mechanism is the stickiness of your urethra. And some of that maybe goes away a little bit with menopause and less estrogen. But I'm not sure.
When my sister went in to get her continence checked, one of the big articles in the urologist office was all of the diet sugars, whether it's Splenda or Sweet Low or Equal.
Yes, they're all
are
terrible.
bladder irritants.
They're all terrible. Yeah.
Even
Yeah.
stevia to a certain extent, but less so than
I've had a few patients recently have issues with I forget what it's called, the stevia soda and like bladder stuff, but research definitely supports caffeine, carbonation, and artificial sweeteners as being pretty consistent bladder irritants. So they can definitely contribute to that infrequent urgency if they're taking in irritants. Or are you wearing, I'm just noticing your witches. That's fabulous. For those of you who can't see, she's wearing a beautiful witch jacket thing that's fabulous. Wow, I feel like I should have shown my Halloween cheer a little bit more.
candy corn was good, but her was
So let's move into bowel. Again, I start with the same. Do you have any questions about your bowel function? General question. How frequently are you moving your bowels? Some people think once a week's normal. I would disagree. Some people think 5 times a day is normal. I would also disagree. But you kind of people often don't talk about how often they poop. So it's a good question to ask. You can kind of tease out some stuff. Childbirth history, injuries. What's your stool like? I should have put a picture. The Bristol stool scale. Everybody know it?
Oh, yeah.
It can be a good one to pull out. Like, what does it look like? I always say it's my favorite picture, and then it becomes a little joke. I could digress, but there are cakes on the internet of.
What?
There are pictures of cakes with the Bristol stool.
Sorry, my brain just went there and I cannot come back.
And then, do you have any fecal incontinence? Do you pass gas when you don't want to? When you go back to the bathroom after you poop, do you have more poop again after you wipe? And then how much are you losing? Same question, basically. If they change their clothes, are they using pads? And then sexual function. I always ask about sexual function. And I ask generally, do you have any concerns about your sexual function? I didn't put any of the studies in, but there's some good research behind patients want us to ask about their sexual function because they don't want to volunteer the information, but they want to know. So you can always ask about sexual function, especially in the case of urge urinary incontinence or pelvic pain. People might have painful intercourse if they're having penetrative intercourse, or men might have concerns about their sexual function that's related to their pelvic floor. It's time to practice. Okay, what we're going to do. Ooh, that was cool. I didn't know I made that happen. So pair up and do a little bowel bladder screen, and make it interesting. If you are being asked, try to make it interesting for the asker and ask some follow-up questions. And this is a good time to practice. It's a safe space. You all seem to know each other. So get your giggles out. We'll take like maybe a few minutes.
Questions I ask in home care.
Yeah.
We always have to do a skin inspection so you know if you've got pressure ulcer. I always check to see if they're wearing some kind of incontinence. Because, oh no, I don't have any problems, and yet
Right.
they're wearing.
But they're wearing,
incontinence.
yes.
That always is.
Yes, it's a good, pretty telltale. And then sometimes you can always tell, like, when you look at someone's skin, like if you're looking around their anus and like their skin looks terrible, you're like, I think that you're less continent than you're telling me you are. Okay, so I'm going to stop talking. Break up, practice a little bit. So, anything interesting come out of that? Any questions or ideas or comments? Are you guys? A lot of leakage. Are you guys?
She got creative.
I'm glad you got creative. It sounds like some of you are already doing some of these questions with your patients. How many of you are doing some continence screening already? Other than you mentioned skin assessment and
Yeah, skin assessment.
so Deborah's doing some.
Because she was leading me down a garden path with, well, and you want to say, well, how often are you getting on the toilet? Or how often are you thinking you're getting up and going to the bathroom? Like you were talking
Right.
about, how often do you poop?
Right.
How often do you get up and climb the stairs to go to the bathroom?
Mm-hmm.
I mean, it's like, it can take you 2 hours to do a really good assessment.
It can,
Sometimes you
yeah.
don't have all that.
Totally. And it's all about kind of having the questions ready if you think it could be an issue. What were you going to say, Katie?
Well, one thing I was going to say was the fact that we're all nurses here, and the conversation is a lot different than if you
Yes.
got non.
Right. Totally. We in healthcare are a little more open about our stuff than a lot of other people. And I think especially like pelvic PTs are the same way because we go to classes and we're all, have our underpants off at one point or another. And, you guys are also all up in people's grills with all those sacral wounds, right?
My mom was a nurse for like 40 years, and she would, like, the little old guys, and we're talking ancient, 90-year-old ancient
Yeah.
mariners, she'd always look at them and say, so, how's your water been? And they knew exactly what she was talking about. So it's
Yeah.
definitions,
Mm-hmm.
and what one person thinks is appropriate and what they call it.
Right. A lot of people don't know what incontinence is. Like they just don't know the word. So that's something else to consider is if you're asking, are you incontinent? They might not have any idea what you just asked them. So they're going to say no.
I found that. Okay. If they're asked if they're incontinent, and they're like, oh no, I don't have a problem. I said, you don't leak urine when you're laughing, coughing, choking, and then they're like, oh. Do you wear a pad? Well, I wear a pad just in case. Most of the time, it's on the way to the bathroom.
Mm-hmm. That's a big one. That's what I'm hoping to help you guys treat by the time we leave today. So kind of pulling it together for what we've gotten from history. If someone has stress urinary incontinence, we kind of talked about it. They're going to leak on a trampoline. They're going to leak when they cough. They're going to leak when they throw up. They might leak when if there's someone who's not moving around a lot, they might leak when they go up the stairs. They might leak when they rise out of a chair. And then urgency, leaking on the way to the bathroom. They might also tell you sex hurts if they're having penetrative intercourse, if they're being penetrated, because their pelvic floor might be a little bit toned. And then my exam is going to look a little different from yours, but this is what I do. I'm going to watch them move, watch them walk, see how they're standing. Let me borrow this model for a second. Can you pass me the model? So if you're standing with... okay, am I in the thing now? Okay, so if you're standing with good posture... this way so all of you at home can see. If you're standing with good posture, your pubic symphysis and your ASIS, these points on your pelvis, should line up in space. So imagine if you cough, right? You can visualize that your abdominal contents are going to be over the top. Can you come up here and hold the pelvis for me? Because I can't hold this and point and hold the microphone all at the same time. So can you hold this way? Perfect. That's perfect. So imagine if you are standing with good posture, you sneeze. The force of your abdominal contents are going to kind of shear over the top of your pelvis. But if you're standing with a posterior pelvic tilt and you sneeze, your bladder kind of becomes a trampoline for all your abdominal contents. So if you see, those little old people who are walking around like this, of course they're going to sneeze when they leak because everything is pushing right down on their bladder. So that's kind of why posture matters. Okay, thank you. My Vanna White over here.
Crede maneuver where you're pushing down to completely empty your bladder?
I don't necessarily like that very much, but some people don't. Some people have incomplete emptying, and maybe they need to. But for most people, remember the way we were looking at that diaphragm, pelvic floor video that I kind of showed, that little GIF with the movement. When you sneeze, it's a forced exhale. So your pelvic floor should be contracting, right? You want, in theory, we don't leak when we sneeze. Some of us do, some of us don't. But if you are pushing down, you're creating that similar pressure from above, and sometimes our pelvic floor contracts in response to that. So if you're trying to empty your bladder and you're pushing down, your urethral sphincter, your pelvic floor are probably contracting, so you have to push more to overcome the resistance of your pelvic floor closing around your urethra. Does that make sense? Mm-hmm. So if you need to, yes, but for the most part, we shouldn't have to strain to empty our bladders.
Is that mostly used for spinal cord injury?
Probably, yeah.
They don't have the...
And now they usually will do intermittent self-catheterization following spinal cord injury, which makes more sense in terms of pelvic floor health. I mean, not great for UTIs, but... So going back to my exam, I'm also going to look at their perineum, their rectum, see how they move, right? Can they contract? Can they relax? A lot of times, especially in folks who have higher muscle tone pelvic floors, I will not see very much movement when they contract because there's nowhere to go. Their pelvic floor is already lifted. I'm also going to palpate both externally and internally, looking for muscle tone, tenderness, contraction quality, strength. Then I'm going to look at prolapse if they're female. I think that might be part of things. I suppose males can have rectal prolapse too, but it's not as common as prolapse in women. Here's what I might find if someone has stress urinary incontinence. Do you think they're stronger or weaker? Weaker. The slide's kind of giving it away, but they're usually not as strong. But more commonly, it's a pressure issue, right? It's poor coordination between diaphragm, pelvic floor, abdominal wall. They might have prolapse, which is essentially a pressure syndrome. Their perineum, I asked them to cough, might go down. They might even leak when they cough on the table. And then am I seeing them holding their breath? The people who are you have them, I always have them stand. I want to see a little squat. People are I know there's a pressure issue, right? If they're having to, there are a variety of ways that we can stabilize our trunk, right? One way is, you breathe, you turn things on, you move. Another way is you hold your breath, you move. One of those is better than the other. Breath holding is not an ideal strategy. If you're at your peak, I was telling a patient this the other day, if you have to lift a car off your kid, fine, hold your breath, because you need the stability if you're going to try to lift that car, right? If you're doing something that is far above your normal strength, you're going to have to Valsalva to give yourself the stiffness. But for most things, you should be breathing, because if you're not breathing, you're creating pressure that can be suboptimal. Questions about that idea? It's kind of a... And then we already talked about this. So urge urinary incontinence, I'll probably find elevated pelvic floor resting tone. So go back to your side view image of pelvic floor. Let me borrow one of these. Yeah, any of the section pictures will work just fine. So imagine, if you will, that you are feeling like you have to pee, and you're worried about it. What do? You tighten your pelvic floor. You cross your legs. You sit on a towel, right? Stick your finger like my 5-year-old daughter does when she doesn't want to use the potty. No, I don't have to go. So imagine, if you will, so the pelvic floor basically makes a hammock between tailbone, pubic bone. And imagine that pelvic floor, instead of being this nice low hammock, is a shallower hammock. And then let's say you're a chronic ab gripper and you turn on your abs. So you've lifted your pelvic floor up into your bladder, and then you've squeezed your abs. So that can create more pressure on your bladder, which can make your urge more prominent, and also a little less space for your bladder. So a lot of times when someone either pees too often or pees on the way to the bathroom, I find that their pelvic floor is lifted. So I'm not going to see movement upward. I'm not going to feel movement upward. When I first started doing pelvic health, I was like, oh, they're just really weak. They can't contract their pelvic floor. And then, oh, wait, it's not that she can't contract, it's that she can't get down all the way, right? Imagine if the example I like to use is your elbow. If your arm were stuck here, right, if you couldn't straighten your elbow anymore, and I ask you to bend your elbow, you're not going to go very far. But if you can get to neutral, right, your pelvic floor has more room to go from low to high. So some of these assessments you can do externally, right? You can feel someone's perineum through their pants, against their skin at their perineum, and kind of feel what happens when they contract the pelvic floor. Does nothing happen? Does it contract up a little bit and then relax down? They might be tender. The same way you can get those stressful weeks and your shoulders get really tight. Your pelvic floor can do the same thing. You can get tender knots in your pelvic floor, and sometimes massage treatment, trigger point treatment can be really helpful to reduce some pelvic floor muscle tone. I also am really nerdy about fascia, so I do a ton of fascial release work internally. I keep hitting the wrong button. Okay, with fecal incontinence, you're probably going to see impaired anal sphincter strength. Your anal sphincter is innervated a little bit separately from the rest of your pelvic floor. So it's possible to contract your pelvic floor and not contract your anal sphincter. So a lot of people just need some training on like how to find their anal sphincter specifically versus the rest of their pelvic floor. They might have irritated skin, like we were talking about. They might have poop on their skin. A lot of people with fecal incontinence are the butt grippers, right? Yes, when they contract the pelvic floor, they squeeze their butt. Questions about kind of exam stuff before we move on? Okay. Oh, I keep pressing the wrong button. So here we are to treatment. Excuse me. Cognition, this is a big one. A lot of minimally invasive treatments for continence require intact cognition. A lot of education is going to fall not helpful if someone can't cognitively process it, take it in, and learn it. There can be medication treatments for people who are cognitively impaired. Sometimes pessaries can work for women with urinary incontinence. They just go once a month, once every 2 months, have their pessary changed and cleaned to their urogyne. And if you're having someone who's incontinent, who has impaired cognition, probably talking to their PCP or nurse practitioner or a specialist makes more sense than sending them to me.
Sorry, what's a pessary?
Oh, a pessary. Sorry, I will actually get there. A pessary is they're usually made out of silicone, and they're a variety of shapes, but it's basically, I call it a sports bra for your vagina. And so it's worn internally, and they're usually either used for uterine prolapse or for stress urinary incontinence. And they basically kind of help hold everything up. So if you're having stress urinary incontinence that is associated with your urethra being a little hypermobile, a pessary can kind of help close off the distal part of your urethra, kind of support things. They're often used in older women with uterine prolapse. I've had a few of my postpartum patients with prolapse use them. They can cause vaginal erosion, so they almost will prescribe, especially if you're in a low estrogen state, a topical estrogen to use with it. They can be really helpful, and compared to like a sling surgery, It's like way less invasive, way lower risk, and I think it's something worth trying. They can be hard to work if you don't have great manual dexterity, so it kind of has to be the right person to use them. But that answer your question? Okay, they're kind of cool. There's like a billion different shapes, and so I always educate all my patients on bladder health, kind of like we've been alluding to. But here's some norms: 5 to 8 P's a day, every 3 to 4 hours when awake, 0 to 1 night voids. Most people are probably over this. So avoid just in case P's. That's the, I just woke up an hour ago. Now I'm going to go to work. So I pee before I leave the house. I'm going to drive 20 minutes to get to work. I'm going to pee when I get to work. Then I'm going to pee before every meeting. So pee when you have to go. That's what I teach people. Wait till you have to go. If you don't have to go, don't pee. No hovering. There's my picture. So try this with me. Okay, sit on a chair like you're sitting on a toilet. And pull back your chair up a little bit because you're going to have to stand up in a moment. Notice what your pelvic floor feels like. Okay, relaxed, neutral. Just check in. And then hover a little bit, like you're hovering over a porta potty. Right? What does your pelvic floor feel like? More relaxed or tighter? Tighter, exactly. So if you're hovering, you have to have more pressure to get the pee out. So if you hover, stop. If your friends hover, stop.
And stop anyway. You leave a mess on.
Exactly. So
But if there's no seat covers.
use seat covers.
No, do not use seat covers. They are filthy.
Okay, so
Yes, think about it.
So,
They flush, and it's paper.
I actually rabbit holed once about this, and there is a team of researchers who do research on this, and they went around to public bathrooms and took swabs, and they found that the dirtiest things in the bathroom were not the toilets. The toilets were like far from the dirtiest. It was actually the little trash bins in the stalls are the grossest things. Toilet seats, and if you compare a toilet seat to like the handles on the exercise equipment at your gym, the toilet seat's probably less gross. So, people at the gym like, ugh. Here's another quick bladder trick. We feel the first urge when we're about half full. A lot of people go on their first urge. If you ignore your first urge, it'll go away within 15 minutes. Try to go on your second urge when your bladder's about 3/4 full. So if you have a client who's going every hour, they might be going on their first urge. And if they go on their second urge, they might make it to an hour and a half. It's way fewer bathroom trips than a day. And if someone is a fall risk, it's way better to have fewer trips. Hydration, more concentrated urine can also be a bladder irritant. So going back to your question, let's say someone doesn't have any water for 2 days. They might have more urge incontinence because their bladder is more irritated by their concentrated urine. It's also stinkier. So if you're going to leak, it's going to be stinkier if you're dehydrated. Per the Mayo Clinic updated their guidelines this year. This is a lot. Men, 124 ounces a day. Women, 88 ounces. Should be mostly still water. Are we drinking that much? Probably not. But could we drink more? Probably. And it should be mostly still water. I've had clients who drink like 5 LaCroix a day and are leaking all over the place, and they switch to water and they're suddenly continent. So stick to still water whenever you can. Some irritants, we kind of talked around this a little bit, but coffee, carbonation, artificial sweeteners for UI. And then if someone has a more sensitive bladder, the above plus tea, alcohol, citrus, and hot peppers.
That's everything I drink. Tea and alcohol.
I know.
There's some good stuff on this list.
Oh my God, hot pepper.
And
And I like to flavor my wine with citrus.
well, I mean, a small amount of citrus, unless you have a sensitive bladder, citrus isn't going to impact you, right? Different people have different sensitivities. And the Interstitial Cystitis Association has a huge list of possible bladder irritants that is ginormous. Everything from cured meats. Right. So one can rabbit hole into all this stuff, but these are the big kind of research supported ones. Okay, so here's where we get to more treatment. The first step is to reduce urge urinary incontinence. This is always what I treat first if someone has mixed UI. This is going back to the elbow example, right? If someone's weak and they're only contracting this portion of their pelvic floor, I'm not going to shrink train them because I want them to be strong in the whole range, not just in the top part of the range. So I want to help them get to normal resting tone. So I might use the first example we did where we were sitting and breathing, feeling what our pelvic floor is doing. It can be a good intervention to help someone find their pelvic floor and relax a little bit. Educate them on the stuff we just talked about. Increase their void spacing. Get them to stop the just-in-case voidings. And if someone has urge UI, I always assume that they have a high-tone pelvic floor. They might not, but I'm not going to give them pelvic floor contractions for the reason I just said, right? I don't want to train this range. I want to train the full range. And then urge suppression techniques. We alluded to the tiger. So if you are really frightened, I was so scared I peed myself. I was so scared I pooped myself, right? So some of the breathing techniques that we did activate your parasympathetic nervous system, which is going to inhibit bladder contraction. So this is where the urge suppression techniques come in. I think I put these steps on one of those handouts. Great. So when you feel an urge, be still, sit, relax, breathe, visualize success, walk to the bathroom, and then you can kind of get into the cycle. If you feel like your patient can contract their pelvic floor well and relax their pelvic floor, adding a pelvic floor contraction can also inhibit detrusor contraction. But if someone's just going to turn on and not turn off, we're making that bladder sandwich. So this is what I teach first, and I add the contraction if I think they need it or if I think they can do it well. So for stress urinary incontinence, again, want to get their pelvic floor tone normal. Cochrane reviews from last year, there's some good research support on pelvic floor muscle training for incontinence. 8 times more likely to have their incontinence cured. It's pretty cool. And it's more time than having surgery, but way fewer, the possible risks are almost nil. Okay, I like this graphic. Can you guys see this? So we're going to practice some pelvic floor contractions. I like this picture because it's showing before you contract, kind of a straight shot for everything. You contract, everything moves forward, closes off. I don't like to call them Kegels because there's a move in like anatomy right now to stop naming things after people. So Alcock's canal is now the pudendal canal, and I don't know who Kegel was, but he didn't find my muscles, right? They're just my pelvic floor muscles. They were there all along. So let's practice. So when you're contracting your pelvic floor, sit up. You've got a few different parts of your pelvic floor. So you've got your pictures in front of you, your anterior triangle. So you can think about cues I might give: stop urine. I might say nod your clitoris, make your clitoris move backwards, like towards your vagina. For a guy, I might say stop urine. I might cue them. I might say lift your perineum. Your anus, you can think about closing your anal sphincter. So that's the superficial muscles. And then if you lift the deeper muscle, that's going to lift your pelvic floor, lift your perineum up off your chair. I don't see any of you going up in the chair. If you squeeze your butt, you're going to rise up in the chair, right? It's just it's like you just showed me. So what you're looking for is, if they look like they're working really hard, they're probably finding their pelvic floor, or they're working on it, right? If they look clueless and they're going up and down in the chair, they're probably clenching their butt. And this is something you can help someone feel. If you sit on your hand, you can feel your perineum. And then if you contract your pelvic floor, you should feel that lift a little away from your hand. There's a little less pressure. So there's ways you can teach people to contract their pelvic floors. Mirrors can be great too, especially for guys. Show them their perineums and can help them a lot figure out what's going on. And then dosing. This is the hard part because I can put my fingers there and I can see how long someone can hold. You guys are probably not going to be doing internal exams, is my guess. But you can ask someone with good cognition, good awareness. Okay, how long? Okay, go ahead and turn on your pelvic floor. Tell me when you lose your contraction. Okay, 3 seconds. Let's see how many of those you can do. So you see how many they can do, and then you say, okay, do that 3 times a day, right? So if they hold for 3 seconds, they do 5 of them, 3-second holds, 5 times, 3 times a day. And then as they get stronger, increase the hold time, increase the number of reps. So that's for slow hold. We have 2 fiber types in our pelvic floor. Slow hold is posture muscle. Quick flex is quick muscles are for sneezing, coughing, jumping. These you want to do on and off. And the goal is a certain number of reps. That number of reps you can do 3 times a day. Sorry, I'm running over a little bit.
You're fine.
Okay. Try to isolate your pelvic floor. Your deep core, your transverse abdominis, and your pelvic floor work together. So when you contract your pelvic floor, you're probably going to feel some deep abdominal contraction. But if you're getting a full trunk movement, you're not isolating very well. If you're squeezing your thighs together, if you're rising up in the chair, you're not isolating very well. And it's not like those other muscles are bad, but we tend to, when we're fatiguing, we tend to use those overflow muscles. And it can be a good way to know when we're getting tired. And so for those of you who we've talked about who might have some stress urinary incontinence in this room, try it on yourself. Be honest, see what you feel. How long can you hold? Are you losing it? Are you holding your breath when you're contracting? Good questions. And then position matters, gravity matters. Lying down is easier than sitting. Sitting is easier than standing. Here we go. Here's the pessary. We kind of talked about this, but let's see. Jumping too many times. So basically, like we talked about, internal vaginal support. You can use it for uterine, anterior wall, urethral. Might reduce SUI. Urogynes, not every urogyne fits them, but most do. Some gynecologists also fit them. A good way to know where it fits them is to call your friendly neighborhood OB-GYN clinic and say, hey, does anyone fit pessaries? Or do you know anyone who does? And they'll usually rattle off who fits them, who they send their patients to. And like I said, they're not for everybody, but for some patients, they can work really well, especially if that's a cognitive issue, and they can have someone else manage it for them. Surgical interventions, I did not really rabbit hole into this. Basically, there are some surgeries with good cure rates. They also have a variety of negative outcomes. I'm sure you've all heard of mesh if you watch TV at all.
10:30 at night.
Correct. So there was a new review study just this year. So if you're curious, I point you to that reference. New review, and there's also a Cochrane review from last year, but this review tried to compare surgeries to each other versus surgery to no treatment or different treatment. Okay, this is probably going to be really hard to read. This is from this study. It is a fecal incontinence screening pathway, but basically it says if they have bad stuff, right, impaction, something that you're really worried about, they have rectal prolapse, sphincter injury, a fistula, some other deformity, send them to colorectal. Otherwise, address what's going on. Right, see if you can improve their access to a toilet. See if they have loose stools, if you can firm up their stool. Manage constipation, pelvic floor muscle training, and then containment as far as minimal, less invasive interventions. Basically, this is saying if they are having stress fecal incontinence, they're probably weak. If they're just seeping all the time, their internal anal sphincter might not be working well. I can't help their internal anal sphincter. It's skeletal. It's smooth muscle, but external anal sphincter is voluntary muscle, so we can train that. But if it's internal anal sphincter dysfunction, send them to colorectal.
What about electrical stim?
We used to do more of that. That could potentially help the skeletal muscle, but I'm not sure if that's going to have much of an impact on the smooth muscle. I really don't know the answer to that in terms of internal anal sphincter, whether that can help or not. But it's a good idea. I'd be curious. Maybe I should look into that a little more. But then treat diarrhea. You all are nurses, right? You know some interventions to help people stop having have more solid stool, right? It might be add some soluble fiber, treat with medication. And they can work with primary care, naturopath, nutritionist to help improve their stool to get more in the middle. And then pelvic floor muscle training. This is a little different than urinary incontinence. We've got this cool thing called the recto-anal inhibitory reflex, or RARE. And it takes a longer pelvic floor muscle hold to activate that. It's going to kind of slow things down. You got to hold for 30 seconds. So pelvic floor muscle training is a little different. This group has been doing studies where they do 10 holds, shorter ones, the length the patient could control, and then 30-second holds times 3, doing it 3 times. And the results, same group a couple years later, were pretty good. 16 weeks of treatment, 5.16 odds higher of reporting improvement of incontinence symptoms in the muscle training group, which is kind of sweet. Okay, referral. This is a quiz. We're getting to the fun part. Sorry, I'm a child of the 80s. I saw Ghostbusters like a billion times, and my daughter was like, "What's that, Mama? Can we watch it?" I'm like, "No, we're not going to watch Ghostbusters. Maybe later." Okay, so let's say you have general concerns. Someone has incontinence. Who are you going to refer to? Yeah, Pelvic Health or PCP. Neurological processes. They might have Parkinson's, stroke. There should be more. Sorry, my animation was not good. They're going to go to neurology. Yep, Gave you the answer early on. Significant prolapse. You can see it. They use a pessary. Refer to Urogyne or Urogyne, exactly. Mobility challenges plus incontinence. You have concerns about their mobility. They've fallen. You're worried they're going to fall. Orthopedic injury surgery. Refer to PT. Yay! And if your patient lives in the middle of nowhere, any PT is going to be better than no PT, right? Working on hip strength, if they can't get out of a chair, is going to help them leak less, whether or not they're working with a pelvic PT. And even if they're not getting home health PT, they probably should be. Fecal incontinence referrals. Any of these things. Sphincter injury, surgery, the passive seepage. Refer to colorectal. They can bypass me. They can go right to colorectal. And then just a little bit about us. We offer pelvic PT Seattle, South Mercer Island, and Gig Harbor pelvic PT. So if your clients are anywhere near there, we would love to see them. And then other directories, Herman and Wallace is where who I trained through. They have a directory. And then so does the APTA section on women's health has a directory. And then I had a couple case studies. We could stop. You can review case studies on your own. It's up to you. Okay, let's do one. Great. So these were not really that kind of made these first two up. Sally, 72, sharp as a tack, lives at home with her 80-year-old husband. When she comes in for wound care, she reports that she leaks urine when she gets out of a chair. You see her struggle to get out of a chair and notice that she can't continue a conversation when she moves from sitting to standing. How might you help? What thoughts do you guys have? What do you think might be going on for poor Sally?
Stress.
Yeah, I would agree. Yeah, sounds like stress incontinence. Do you notice any pressure things going on? Yeah, she's probably holding her breath.
So she won't pee.
So what?
So she won't pee.
Well, it might be making her pee more because she's making more pressure, right? It might be that she doesn't have the hip strength or the core strength to get her out of a chair without stiffening everything. So what could you do as her nurse, her wound care specialist, to help her?
Referral.
That's always a good one. So things you could do right away. We kind of covered all of these things. You could encourage her to exhale as she stands. Because like you missed earlier, there's this really cool GIF we watched about pelvic floor and the diaphragm working together. But if you initiate an exhale as you're doing your activity, it's going to help you engage your pelvic floor and your abs in a way that's coordinated versus a pushing down kind of way. So that might be an easy intervention that you can, or have her say go or up or something can help her engage her pelvic floor a little bit better. We just talked about exhales. Pelvic floor engagement lifts up, breath hold, downward pressure, which might be pushing her pee out. Yeah, PT might be a good choice, preferably pelvic health. But, if someone's having trouble getting out of a chair, yes, pelvic PT can help, but they just need to be stronger. Okay, I have another little brief male one. Can we go on to my real case study? And I'll let you read my made-up one. We can come back to it if we really want to. So this is an actual patient who I'm actually still treating. I've changed a lot of details. Ed is 78. He lives at home with a 75-year-old wife who works part-time. He had a TURP a few years ago. He had a kidney removed due to cancer. No falls, but concerned about balance. He leaks when he gets out of a chair, when he walks to the bathroom, when he lifts bags of compost for his garden. He walks in parades, has back pains with walking, and he was hydrating with a mix of Diet Sprite, water, and ice, about 3 cans a day. Here's what I found. He had the kind of classic old man posture, right? Not the worst case of old man posture, but definitely had that going on. He held his breath when asked to stand on one foot. He held his breath when asked to do a bridge. So I'm pretty sure he's got some breathing mechanics. When asked him to crack his pelvic floor, he gripped his butt. He was kind of weak. We grade out of a 5 scale. 5 out of 5 is normal strength. He was a 3. He could hold for 5 seconds. I want people to be able to hold for 10. He was a little weak. Here's what we did. We did urge suppression education, some pelvic floor muscle down training, which was the sit in your chair, drop your pelvic floor thing. Eventually, when his pelvic floor tone got a little more normal, I gave him some strengthening. We worked on isolating his contraction. He did some contractions. He actually did his homework, which I was pleasantly surprised by. We talked a lot about bladder health, bladder irritants. I strongly encouraged him weaning off diet soda. Shockingly, he listened to me. And 3 months later, he had less SUI, now only with lifting compost, and not as much urgency, only if he waits too long. And then I had seen him for a lot of visits that were in the afternoon. And I finally saw him in the morning. He's drinking this big 20-ounce cup of coffee. And I'm like, how do you take it? With 6 pink packets. So we kind of went back to the drawing board and reviewed bladder irritants. And we know coffee's not great. But if you're going to... Most people really like their coffee, right? But it's easier to get rid of the sweetener. So I encourage him to get rid of sweeteners more. A year later, no UI. Still working on balance and fall risk reduction. No artificial sweeteners in his diet. Hooray. He's still drinking like 20 to 30 ounces of coffee a day, but no sodas. He still takes his coffee with 10 brown sugar packets. And shockingly, his doc has some concerns about his A1C levels. So you can't fix everything. But
It's not just that sugar that's the problem.
no, it's not. It's not. He also, people are just funny. They have funny habits. People who I had one patient who did not drink alcohol except for when she couldn't sleep. So she'd wake up in the middle of the night, have a little glass of wine and go back to sleep. And would have trouble making it to the morning. She'd get up and pee. Kind of funny. But, well, questions, thoughts? Anything else I can answer for you while you've got me as your captive speaker? Okay. Well, you all have, here's my info. And that's really tiny. There's a stack of my cards there. Please take cards. Reach out with questions. I would be delighted to hear from any of you. I'm happy to see your patients. I'm happy to help you find other PTs that are closer to where your patients are. Those directories are great. Seattle's a great pelvic health community. Thank you for letting me talk to you. Thanks for your attention.
Right, thank you.
And then there are a billion references, of course.
I have a question. What's
Yeah.
the average time frame for noted improvement? Obviously, there's a huge variance, but
Right.
let's say a nearing 40 woman who has vaginally delivered 3 children, asking for a friend.
So if it's primarily, it's usually not just a strength issue, but let's say it's a strength issue. Muscles to get bigger and take up more space. Sometimes in that case, your friend might have some extra movement in her pelvis, right? She might have a little bit of prolapse, but bigger muscles take up more space. Muscles take 18 to 20 weeks to get bigger. So it's 3-4 months. But you can have some improvement before then, depending on, let's say she's drinking 5 LaCroix a day plus 2 cups of coffee and sparkling wine with dinner, right? Those dietary changes can make differences faster. If I have someone who's kind of like your friend, I will usually try to see them once a week for maybe, 5-6 visits, and then space out a little bit more. Because I like to have some contact for 6 months can be nice, because especially moms of 3, right? Kid gets sick, see her for 3 weeks, right? And just try to kind of keep things happening. So long story short, can see some improvement in as little as 4 to 6 weeks, but then you'll have another kind of slow improvement over the next few months. Cool. And if someone has just urge UI and all they need is to learn some urge suppression techniques, have some fewer bladder irritants, that could be 2-3 visits, right? Maybe 6 visits. There's usually something else that someone wants to work on PT-wise, but urgency can happen faster.
Cool. Thank you.
You're welcome. Thank you all.
Thank you, Julianne. It was great hearing about this. I'm sure those who are at home also have a lot of questions, but I'm sorry, you'll just have to call us or email us, and we'll go from there. Get in contact with a pelvic floor health specialist, and they can help you with that. Now we want to thank Angela from Medline for.
I totally forgot that I'm supposed to talk.
Yeah. We want to thank her for the meal. Angela is in charge of the skin health program at Medline. And so we're going to turn the microphone over to her for about 10 minutes to talk about some options with Medline.
We'll make this nice and quick. Don't worry.
She said she's going to make it quick.
Yeah.
So
Sorry I talked for so long.
it means we get more continuing ed credits.
They're way more interested in what you have to say. Okay, so some of you may have seen this, but this is called the Skin Champion Program or Skin Health Solutions. So when I came to Medline over 5 years ago, I worked on the wound care team at Good Sam, and my boss had said to me, I said, I'm going to go work at Medline, and she said, Angie, don't go do that. Medline is a Walmart company. And I was like, well, I have 3 kids. My husband's a teacher. I shop at Walmart. I'll give it a try. So it truly has evolved so much within the past, since I've been here, we've invested mass resources into clinical focus groups. A lot of our sales team are clinicians. We have research and development, medical affairs, key opinion leaders. Like they're here to stay. And a lot of times because we're more cost effective, people don't understand how we're able to get to some of the price points that we have. And a lot of times it's because we are the distributor and the manufacturer. So every time you're taking product here, it's going through a Medline channel. So of course, just like anything, there's a charge that ends up going to the end user. So we kind of cut out the middleman. But a part of us really investing in clinical services and programs is about 2 years ago. Do I have to use the microphone thing? Is that for the...
Yeah.
Oh, okay. I feel like I'm like on a QVC commercial right now.
Oprah.
I know. Is building programs that are actual resources. Like, how do we move away from, hey, we'll save you 10% and we're your distributor, to actually bringing value? So we took focus groups of WOCNs from all across the country. We asked for their feedback, and they said their common struggles, like this room faces, are they're being tasked with seeing patients, they're being tasked with developing protocols, they're being tasked with finding, like sitting at home reading, medical journals or the woundostomy journal and being up to date on best practice constantly, and it's just impossible. So what this does is we have multiple nurses that sit on the governing bodies of the NPUAP and the WOCN boards, and they're able to stay current on different topics that are coming down the pipeline for trends changing in wound care. So they put together a multifaceted program that's it's different than just a pressure injury prevention program, because everybody has a form of a pressure injury prevention program, but ours is skin health. So we're looking at MASD topics, topics related to current considerations, like the trends in obesity, pediatric patients, just a lot of different topics. So basically, the format of this is meant to be more in a community-based. So best practice for this program, and I have seen people use it in a million different ways, the information that's in here, is having a roundtable group like this. You have a group of WOCNs or nurse champions. They build a team of resources on the floors to be able to be the go-to people on the floors. They meet once a month. They become the wound ambassadors or the champions. The reality of that happening is like, it's hard because you have to pay for those resources to get education. So that's one way that we envision this working, but a lot of times facilities are just wanting bits and pieces of this. So I'll show you one of the modules. So this is pressure injury staging. So this is really hard one-handed to go through this. So we hired one of the chief nursing officers for one of the Providence facilities down in Oregon, and her big key takeaway, and we all know this as well, is that the attention span of people is like nothing. So online education is really challenging when you're doing module-based stuff because people sometimes just click through it. So the intent is provide information that is like when you walk out the door, you actually remember the content. So it's key information based on the topics, and the topics are 20 to 30 minutes in duration. So you get the PowerPoint and speaker notes so that it doesn't have to be just the wound specialist who's conducting the education. It can be a resource nurse or an educator. You get the evidence-based related to the topic. So none of this is Medline said, use our hydrocolloid, whatever. It's all just hydrocolloid, not specifics. Nothing is Medline specific. Included in each module is where the heck we're getting the information from. So this particular one has the NPUAP position statement supporting the information, and various topics have different medical journals. So you're not having to go through Googling where you're getting the information. The other piece of this is visual aids. So we literally print every piece of the visual aid out for you so that you can do reinforcement education. So you do a topic, the staff kind of get it, but then they go back onto their floors and they see a visual aid that they're able to reference for some sustained educational support. But what's nice about this is that you don't have to be Googling, these types of graphics and wondering, where they are or where you're pulling the information from. We have facilities that only utilize this program just for the visual aids. They'll take the visual aids and they'll make trifolds and they'll rotate them around to different floors, and they'll do like a key takeaway. If they don't want their staff doing pressure staging, then they'll do what's the difference between partial thickness and full thickness. And if they can get their facility to understand that one concept, then they checked off their objective of the education. Last thing is, with each module, there's some type of educational support tool. So for this one, it's badge tags. So there's, one of our WOCNs kind of invented the whole apples to ulcers. You might have heard it around, but it basically is comparing the levels of tissue destruction to an apple for a reference for pressure injury staging. So that's the support tool for this one. Some of the tools are like risk predictor scales, little Braden tools, other badge tags, just little things that help reinforce it. And then you get, if you're building a skin champion team, cheesy little lanyards. People actually like them. And then achievement pins. And then you get everything on a USB, so you can duplicate it or you can share the information. So there's 24 modules. We don't charge for this program. It's a value add program for facilities that partner with us. Actually, Evergreen is one of our partners with us. All of the Providence facilities corporately have this program. Multi-care. There's a lot of different facilities that have utilized this program, and like I said, they do it in a bunch of different ways. And we help you with an onboarding program if you get signed up with it.
Home health can use this?
Yeah, home health can have access to this as well. It's a little bit of a different qualification process for acute care. I don't know because I only do hospital-based stuff, but yeah, it's offered in home care as well. Yeah. Does anyone have any questions? No? Okay, awesome. Thank you. I was probably out of that thing the whole time, not talking in the mic.
No, it's close enough.
Yeah, and I have to go to the bathroom so bad because the whole time of that whole continence thing I was thinking about.
Okay, well, thank you for coming to SWOC. Everyone gets 1.5 continuing ed units if you are going for that.
Once, NAPU, $5
Yep.
completing.
And we'll see you guys all in January.